Good morning, everyone. Thank you so much for choosing today's session. And if you're beaming in online, this is the one about the role of public health and healthcare in addressing health equity now and in the future. It is my great pleasure to be joined by some public health and healthcare leaders in the field. It's been an amazing summit experience where we've all been kind of listening to and sharing stories about best practices, lessons learned, all in the spirit of advancing health equity. And we're going to continue that tradition today by having what's called kind of a rapid round, a fireside chat of sorts, no fire, to be able to hear more stories of some of these leaders from the field. My name is Peter Holtgrave. I'm a senior director with the National Association of County and City Health Officials, otherwise known as NACHO, or if you're hungry, Nacho. And we represent the nation's roughly 3,300 city and local or county health departments. And so I am here today not only to bring my own lens around what does local governmental public health look like when we talk about this intersection of public health and healthcare towards advancing health equity, but also with open arms to learn from my colleagues today, as well as from everyone that's at the summit today in today's session, about how we can continue to foster alliances together to advance health equity in the spirit of what we've heard from this morning's keynote from Dr. Christopher, which was so inspiring. So today's session really is about that intersection, and it's about, I'm continually amazed not only by the disparities and inequities that we all continue to see manifest that were magnified through the pandemic, but as we're even hearing from yesterday and today, these go back generations, and the amount of disparities and inequities, whether it's Native American populations or indigenous populations or other people of color, other people of other sexual orientations. This has been going on for a long time. And so how do we, in the spirit of Dr. Christopher's charge, continue to kind of steady ourselves, lock arms, and stand on those shoulders of our predecessors to be able to advance the work? And so really today's conversation, and it's quick, we're only 45 minutes together, it feels like a speed date. So get to know each other, get to reach out to us, is like, what are the lessons learned so far, whether pre-pandemic, during the pandemic? How has that illuminated opportunities around what we do to embrace population health and advance health equity and address the root determinants of health, whether it's how we share data and information, how we partner and ally ourselves with the communities that we're serving, or other types of practices. So it is my pleasure today to really sit back and also listen and engage and absorb the wisdom of my fellow panelists today. To the left of me is Amanda Pears Kelly. She's the CEO of the Advocates for Community Health, or ACH, in Washington, D.C. To the left of her is Chen, who is the Chief Operating Officer of the Asian American Health Coalition that also operates as the Hope Clinic, based out of Harris County, Texas. And next to her is Floritta, who is the director of the Office of Minority Health and Health Equity in the Oklahoma State Department of Health. I'm not going to go into their illustrious bios, so please go onto the app and be able to do that, and just in the spirit of spending more time listening with them and having a conversation with you. And we're going to start first by, I'm going to invite each of our panelists today to take about 3 or 4 minutes to kind of share their story in this space around the role of public health and healthcare to advance health equity. And then we're going to have a facilitated discussion thereafter. So I'm going to go ahead and ask Shane to kick things off, and then followed by Floritta and then Amanda.
Good morning, everyone. So the Asian American Health Coalition was established in 1992 by a community researchers, providers, health people in the health field who really wanted to actually make a difference and start bringing limelight when you're grouping the Asian American population together. This is actually a huge melting pot of people from Pakistan, from China, from Vietnam. So the representation itself is not exactly just a single the health disparity or the cultural language aspect, but it's actually just very multifaceted. And with that, the coalition formed, did a lot of advocacy, but realized that the health service access itself is huge. There's a huge gap. We preached about getting the timely access to hypertension, diabetes management, and cancer screening. But at the same time, where is the access? Where is the service for those who are truly uninsured, low income, vulnerable? So with that, they formed the Hope Clinic. In 2002, we started off with just volunteers and opening maybe once a month, 4 hours at the Chinese Community Center, and gradually became a community FQHC, federally qualified health center lookalike in 2008, and fully deemed health center 330 program in 2012. With that, the Hope Clinic itself, today we actually provide services from pediatric all the way to OB-GYN, behavioral health, dental, vision, and a wide range of enabling services to help people access insurance and as well as access the timely additional social services, housing, food insecurity, and whatnot. One of the things I wanted to actually kind of share is all along this path, we couldn't have done and gotten where we're at if we hadn't had partners such as from the public health sector. With that, we become like the bridge and we become like the community liaison, serving both from the people in the grassroots. We represent the voices of those who are elderly, those who are non-English, limited English proficient, and those who just do not have access and just truly vulnerable, the homeless, the women who are seeking help because of family violence situation. But then at the same time, we also represent the voices of the community to serve as advisory for the public health sector, to provide guidance as well as the information to those who are decision makers, those who are bringing the resources in from high up. So it's both of us, upstream as well as a downstream grassroots reach. And with that, basically with the information that we're able to kind of capture from the hard-to-reach population, we're then able to kind of move it upward to kind of share the disparities, the challenges, the gaps that are actually in place so we can make some systems changed.
Thank you.
All right, I am Floritta Pope, and I sit here thinking, I feel like now they gave me a mic. I'm a preacher by nature. And I looked out and I said, most of the people are in the back of the church. That's what I'm looking at everybody. Nobody wanted to be in the front. So I brought my cloth as I sit as a pastor's wife and so often in my chair, I make sure I put my cloth on to cover my legs. So I'm feeling at home right now, y'all, so careful. I got this mic in my hand. Now, I am the director of the Office of Minority Health and Health Equity. I represent here at the Oklahoma State Department of Health. There are 68 health departments in Oklahoma, and there are 77 counties. And our commissioner, Keith Reed, I'm able to be here in his stead, and I am excited for the opportunity. I'd like to talk a little bit because in this office, it was actually authored in 1994 by the State Board of Health. And then in 2019, it expanded from Office of Minority Health to Office of Minority Health and Health Equity because it wanted to begin to look at those social determinants of health and just expand just beyond just minority health as far as race, but looking at people, those that are in underserved populations and those that are in our, because Oklahoma is very rural, and those areas where people have access to, challenge to getting health. And so, and then COVID came after I got my position in 2019, and therefore we had to begin to stand up an opportunity for individuals who did not have access to technology to be able to get access to vaccines. And so I stood up a call center of about 41 staff. I'd never met at least 37 of them. I did everything virtually. I hired people over the phone, I trained them over the phone and got them ready to take calls. And we were averaging anywhere from 1,200 to 2,000 calls a day. And people were just wanting to find vaccines, getting information, wanted to know about COVID. And so we did that. And from there, we got the CDC funding, we call it Disparities Grant, OT 21-2103, which allowed us to be able to expand the workforce. And I was able to stand up in this office, went from 3 individuals to 21 individuals, and focusing on limited, as you talked about, the limited English proficiency, hired a staff that were able to go into the communities that look like them. So Spanish-speaking, Marshallese, Vietnamese, Burmese, Zomi, and then we had males, females. We were just able to go out, and that's where it all started for me in 2020 when COVID hit. And since then, we're able to sustain those positions, and I'm excited about it. So I'm glad to be here today.
Good morning, everybody. Is it working? Okay, good. I'm Anna Pears Kelly. I'm the CEO of Advocates for Community Health. I have the very wonderful privilege of wearing two hats. I'm also the executive director of the Association of Clinicians for the Underserved. Both organizations serve providers. ACU, Clinicians, we'll start on that side, is about 28 years old, and it was started by providers who were participants and alumni of the National Health Service Corps. So I don't know if you guys are familiar with the National Health Service Corps. It's a really incredible scholarship and loan repayment program. But in any event, it was a group of providers who came together and said, there's so many fantastic professional organizations out there, but there's nobody that's really working to support providers caring for underserved communities. And so that was really the inception of ACU. And I bring it up because the partnerships that we have at ACU, but I think that our members and our providers would speak to in the public health space are absolutely vital. And they're very much, they intersect. It's hard, there's a blurred line, I guess is what I would say. I think when we serve largely health centers, on the ACU side, it's really anybody who's caring for underserved populations. It's not limited to FQHCs. ACH is a national membership organization. We're a C4, so we focus heavily on policy and advocacy for FQHCs specifically. But I think when we talk about public health, and by the way, this is a new add to my schedule, so I wasn't necessarily imagining I was going to just come and listen to this conversation, and now here I am on the panel. But I would say in terms of the relationship between the work that we do, but also when I think about our members, like I said, and the individuals in our network, and the connection to public health, it's hard for me to draw a distinction, because it is a partnership, but honestly, it's one of the same. And I think something that you just said, Floritta, really strikes me, and it's really about people. And whether we're talking about policy and advocacy or looking at data in order to see systems change and try to see and drive health equity, it really comes back to people. And I think, I don't want to speak for everyone in the room, but I suspect we're all here because at the heart of the discussion and our work, and that North Star that's driving all of us, it's about seeing that impact. So I'm really thrilled to be up here. I think these panelists are going to have a lot of really great things to say. I'm going to try to add as much as I can. But I also hope we can have a conversation with you all too, because I think there's a ton of wisdom in this room. I know that came up in the last panel, which was phenomenal. So Peter, I'll turn it back to you.
Thank you so much. And she's reminding me, and you're kind of seeing our little lovely faces there, especially mine from 20 years ago. Don't I look great back then? Had hair. But I wanted to acknowledge that Chris Tallbear was going to represent with the National Network of Public Health Institutes the tribal perspective as part of our conversation. So we hope that he feels better. We will definitely try to channel his example as well in our conversation. And deeply thank Amanda at 7:30 last night, jumping onto a panel that she didn't know she was going to join. But now I want to go a little bit deeper now. And so some of you have alluded to your role in COVID, the benefit of having CDC funding to be able to sustain some of those efforts. And I'm just wondering, when it comes to issues of, especially inequities of root determinants of health, what have been the aha moments through that journey? Certainly we've seen a tremendous amount of activity where healthcare and public health mobilized as quickly as possible. But I don't think anyone has ever caught their breath to step back and say, what did we do right? What did we do wrong? What could we do better next time? And I'm kind of a CQI guy too with NACHO. And so I would invite our panelists to share anything about those aha moments and maybe how you've changed practice as a result of that experience. And maybe, Shane, if you don't mind if I start with you.
Definitely. So, as you know, at the beginning of at the end of 2019, that's when we started hearing lots of news about the Wuhan COVID-19, the virus. And one of which is unfortunate was there's a lot of political media information about the Chinese bringing the virus into the U.S. And so immediately we worked with our local health department to be able to kind of debunk some of the myth, and as well as raise a lot of the awareness for those who are traveling back and forth or basically recently have family members coming in from China, just to raise that public awareness about the true fact information about the virus, to reduce a lot of the racial profiling, as well as the fear that people might be actually hearing from the media and untrusted sources. So that's actually really critical for, especially during the pandemic or any national emergency, that there is information out to the general public in different languages, going through different sources so that there's factual, accurate information being passed out and instruction for people to do what to do next. And with that, we had worked really closely with CDC, with our partners from the public sector to make sure that the information about the transmission aspect, about safety, about masking up is actually there and passing out. And one of the things that we learned is you have to work with the different community media. You have to get the proper information to them so that they can actually convey it in that language or even identify a representation from that community trusted factor, including physicians, including healthcare providers. And this is one of the shout out that we have to all of the mid-levels that we had been so instrumental in also helping us convey the messages to people that they serve. Because a lot of the times, physicians are great, but the thing is, it's also the nurses and also the those who are social worker, caseworker, that help nail the information down and pass it down to the people who they provide care for, because they provide that additional face-to-face encounter. So one of the things that we did really well was we want to make sure that the testing itself, as well as the vaccination effort, is actually trickled down to the truly hard-to-reach group, such as in departments, people that are not coming out, the elderly seniors in the nursing homes. So what our effort did was we coordinate with the local entities to be able to make sure we have the test, appropriate tests, as well as the vaccine, and making sure that we have the team member as well as hire people from within the community. So workforce development, training, to make sure that we have those people going to identify different groups that are very vulnerable, such as like the Burmese, like the recent refugees, refugees, pockets that are within the apartments, pockets that are actually within the nursing homes and whatnot. So with that identified, we then mobilize a lot of our healthcare providers and our health clinical support team to go out and administer the test, the information, the vaccination itself, to truly make sure that the seniors that are in the nursing home not being able, it's so isolated and everything, is able to be vaccinated.
Floritta, I'm also wondering too, and I'm grateful you're about to speak. I've just seen at the local level, I can only imagine at the state level, how COVID crashed through, and you really had to triage and come up with some systems and put them in place. What are some of the aha moments for you in terms of that experience?
Just watching our emergency response team come together, sitting in a room called the emergency command room, and setting up a dashboard so that we were able to make vaccines available online. And then, understanding too that, as you were speaking, many of the underserved populations in Oklahoma were hesitant. Even after we began to explain that this is a pandemic, you need to get vaccinated, they were very hesitant to receive the vaccines due to historical lack of trust in the healthcare system. And so I would say, community engagement and trust was something that we learned out of that situation, and began to bring us all together. Again, talking about that call center, taking those phone calls, when people were holding online for an hour and they're calling saying, Floritta, what's going on? Because it was just really small amount of conversations at first, people just inquiring of what's happening. And so we began to find that a lot of the elderly and those that had limited English proficiency didn't understand how to use the technology. And so there was that digital divide that was there, and became a barrier for individuals being vaccinated or just getting information. And so what we learned is we took individuals, again, trust, engagement, community engagement. We're starting to go where the people are, making phone calls. I got with the faith-based organizations that I knew, started reaching out to preachers and pastors and bishops and saying, hey, you know, can we talk to your congregation? Can we have a Zoom call? I'll meet them. Working after hour with those phone calls, trying to educate and bring awareness, and spent a lot of hours and speaking to the point of hiring people that look like their community. That, I mean, I don't speak Burmese. I don't, you know, but that was something that, you know, even with the funds from the 02-2103, the disparities grant, being able to fund these positions and then seeing the need for them beyond the pandemic, okay? Because some of the disparities that were present, they were there before COVID hit. Individuals that didn't look like me or you did not feel comfortable coming to the health department to receive services. And so now having those individuals that are now going to the events and the community saying, here's what your Oklahoma City County Health Department has for you. Here's what's available in Hughes County. Here's what's happening around, you know, because we're so rural. And then here's a FQHC that's available. That has been a tremendous impact, a lesson learned to know it's important that we utilize community health workers. And those shared voices and their experiences has made a big difference. We'll continue to do so. And our agency has done a good job in that, allowing us through these funds with some of the community health workers. We found other funding opportunities for them beyond the grant, because that's always, you know, a barrier. When the grant money runs out, now what? And our agency has seen the benefit, our state has seen the benefit of community health workers and has put a plan together, a strategic plan, not just a plan, but actionable items. We've often heard people say they're just kind of tired of our plans. We got a lot of plans. What are we going to do about it? And so we've seen health in action just with utilizing our community health workers and then, again, putting together this group of individuals that look like their communities.
That's tremendous. I would love to be able to continue this conversation that you're both mentioning around how do we center community voice in all the work that we do? And not just listen, but center it. And you both have mentioned trust. And a piece I'd like to start with you with, Amanda, is there's talk about advocacy, for example. We in governmental public health can't advocate, we can educate, but our alliances enable us to do those kinds of things. So I'm just wondering, from an advocacy organization perspective, and then certainly to the rest of you as panelists from your own experience on the ground, how do you kind of move the needle in that kind of policy systems of environmental change pieces, knowing that there are those kind of guardrails around advocacy versus education, as an example, relative to engendering community trust to really address these root determinants?
It's a really good question with a somewhat complicated answer, partly because I want to acknowledge that there are limitations for public health departments in particular. Where, to your point, you can do education, but you can't, there's a pretty clear red line around wandering into advocacy and sometimes even policy, although you can inform on policy. But I think this is where the partnerships become really, really important, because, and I just, to kind of build off of some of the lessons learned during the pandemic, something that I think came out of the pandemic, which has continued and been so incredibly valuable, is probably everybody in this room did the same thing, where daily, if not every other day, you had calls with your leadership team, because nobody could see each other in person for a little while. So you had these daily calls with leadership, but you were doing, or our folks at least were doing the same thing with their partners in public health and having conversations about what was working, how can they build off of the lessons that they were learning each other, excuse me, but also how does that then inform the needs around policy and advocacy? And I think where there may be limitations for some in public health, that's where health centers and my organization and others can lean in and elevate the voices of our partners in public health and bring you all in to say, okay, can you please share the data? Can you please share what this looks like on the ground from your perspective, where your hands are tied in terms of what is actually needed, but where there either aren't the resources or the policy in place? And then the organizing that's necessary to support that. A lot of the work that we do, and we heard it in the last panel, which was just, again, it was so fantastic. But, you know, not to call out our hashtag for this meeting, but equity in action, right? And that's a great tag, because that's what it's about. It comes down to organizing, and I think, you know, one of the examples that came up was I think the speed bump. But I think in the context of COVID, and then I think when we look at continued health disparities, I mean, sorry, I'm going to rant for a second here. I have been honored to work with health centers and in healthcare since 2005. And many of you have probably been tenured longer, far longer than I. But for as long as I've been doing this, we've been talking about health disparities, and we've been talking about health equity, and that's been at the root of the work. And yet we're still facing the same issues. And it was almost like the rest of the world woke up between George Floyd and then the unavoidable horror of the health disparities that happened during COVID. And it was this moment of like, okay, maybe finally the policymakers are gonna wake up and they're gonna put the resources to this, and we're really gonna see changes. And I think we have had advances. But there is so much more work to do. And I think elevating the voices of the people on the ground, I think Floritta makes a great point that including hiring people from the community. I mean, I think one of the lessons learned was, we were talking about testing. It was finding the right messenger, determining who had the greatest trust in the community. That's all part of advocacy. You just carry that forward, and then that becomes your messenger and your voice in terms of how you translate it to policy. And I think once it came time for vaccines, I mean, I don't know if you saw this where you are, Shane, but I heard story after story where it was community members who were elders, oftentimes, who came in, who took the risk and addressed the concerns and the worry and the mistrust, got the vaccine, and then they just literally sat in the waiting room and had conversations with other community members and patients as they came in to give them reassurance. So I think sometimes the challenge we face when it comes to advocacy is that we overcomplicate. And the pandemic, to some degree by necessity, made us simplify and go back to roots. And so a lot of the work that we do, honestly, is that simplification to very complex policy issues, but I think it's also just elevating the people and recognizing, again, those barriers or those boundaries in terms of where some of our colleagues can't necessarily lean in the same way.
I'd like to add to the new processes that's now bringing the people to the table. Let's just not talk about them. This is just not keeping them on the menu, but bring them to the table. We've found that we're now starting to open doors to where we're bringing community voices to the table at the beginning, not after we've made a decision, but we're starting to bring them there at the beginning to have those conversations. And that has made a big difference because you got the buy-in. You've got the buy-in of the people. And so often with public health, we've been really busy and known for taking resources to those communities and not really finding out what is it they really need. And so we've now started to, even in public health, with the health departments and partnering with other partners, businesses, community-based organizations, even other state agencies. So I'm seeing the health department coming together. We're meeting with the Office of Mental Health. We're starting to have meetings and bringing it together because it's for the holistic approach of meeting the need of people. It's all about people. And then having conversations, bringing those community members, bringing those key people together. We found that it's working. It's going to take some time, but it's working. And I like the way Dr. Christopher was saying, we just got to keep going. We got to keep doing it.
Yep. And I'm mindful in my conversations with Chris Tallbear, one of our original presenters, that he talked about the rich dialogues around listening sessions and to have solution-oriented conversations that are, again, centered on community. And honestly, how do we as public health kind of get out of the way and healthcare and be led by community, and what does that mean in that process, right? We think that we kind of have the science, the tools, the resources that are critical, but if we don't have this at least be a co-led process, what are we really trying to achieve in the long run, and is that really addressing the root causes of these determinants of health, or are we still addressing the downstream versions? So I want to shift to sometimes best intentions don't go well. So are there examples that any of you would like to share about you've identified a disparity and inequity, you're locking hands with community, and it just crashes? And what did you learn from that process that you might do differently next time?
I'll start. I know, let's use COVID as another example. So during COVID, one of the things that the public health sector really are interested in is just information collection, because with the virus itself, there's so much unknown, right? And so they wanted to actually kind of gather information. How are you feeling? Who have you been in encounter with? Dose 1, dose 2. What brand is the dose that you got? They wanted to actually get as much information as they can to truly understand where the spread is, tracking of like the transmission aspect, but they're not realizing for many of the folks, it's a little bit invasive. And the trust aspect that we're trying to get them to trust the process, get the vaccination, get the testing, is actually hindering, negatively impacting a lot of the people who may find that this data collection is a little bit too much, too soon. And then so for the information itself, then we had to kind of bring the concerns, public concerns, to the attention of the decision makers as well as the public sector to make sure that, first and foremost, we're trying to administer testing, we're trying to administer vaccination. Gathering the information itself takes a long time with translators and with the even with the community health workers. So then it becomes a long process before you can vaccinate anyone or you can actually administer the test, right? And so that information collection itself and then being able to transmit that becomes also cumbersome and weighs down on all the healthcare providers across town. So with that, at least it was heard, the concern was actually addressed, and then they shifted a little bit into the way that the information was collected and what information was collected, so that it's not detailed to where do you live, what is your birthday, what is your detailed information, do you work anywhere, do you have, how many people are in your family, so at least we want to make sure that just the basic information that's truly needed is collected, so the true process of the transmission, to mitigate the transmission, is actually addressed immediately.
Yeah, Floritta or Amanda? Would you like-
I give the example also during the pandemic, how that telehealth services expanded rapidly. And that was like, that's a great idea, telehealth. And then, everybody doesn't have access to internet. Again, going back to rural Oklahoma, right?
Yep.
And if there was a tower out there, everybody trying to hit the tower, there was some latency, right? There was some latency. And so, again, great idea. And so, but the good thing about it, I'm all about health in action, you all. I'm all about the fact that we are making some strides. There has been a initiative put in place now, the broadband initiative here in Oklahoma, that we're now looking at how to improve that by putting the internet and putting poles in place in those areas that otherwise would not have access. So Oklahoma's doing some things to address. There's some lesson learned from that. Again, it was a great idea, but it was still created barriers and disparities because a lot of people did not have access.
Oh, I think we're watching the timer in front of us, but I will offer a couple things quickly in terms of that I think we're still coping with. And I bring it up because it's going to require all of us working together to continue to advance this. But I think if I am reflecting back on the pandemic, but also just examples in general, one is this shiny object syndrome. Mm-hmm. And everybody was really excited about health equity and, okay, we got to lean into this. We got to address these health disparities. And that came in the shape of funding. It came in the shape of policy, and we have made some progress. But suddenly, they're looking somewhere else. And that shiny object syndrome is real. Mm-hmm. And I think hand in hand with that, unfortunately, is the politicization, applying politics to health equity, which is so horrendous, but it's real. And so what does that look like? Is that changing the language that you use? Is it figuring out the messenger? Obviously we've all been dedicated to doing this work for so long, and I think we have to continue. But I think those are two things that we are dealing with right now that have not halted the work, but certainly are now serving as a barrier. And so I think, again, there are ways to continue on and move around that. But I see that both in the policy advocacy space, meaning policymakers, whether it's Congress or others, but I also see it in the corporate space, mm-hmm. Where there was a lot of attention and a lot of resources being put to this, and then suddenly whether it's because they see a shift in politics and it's given them concern, or because budgets are shrinking, whatever it is, it's real. And so I think part of what has to happen is a renewed commitment and persistence around making sure that this doesn't just fall away and become one of another, number of issues that we're all working on.
So insightful. I think we have probably 5 minutes left, or 4-ish, looking at our time person. I would love a couple questions, if time permits, if anyone would like to raise their hand. We have a person with a mic. Happy to hear from you too, to join the campfire.
I'll just really briefly, real brief. You mentioned public health couldn't advocate. So I would really think it's an opportunity here to explore that, because I think that public health has a role to advocate. I know public health can't lobby, but I think it's important for us to explore the difference. And I know we have governmental affairs experts here, but I think that's important for this audience.
Yeah, great point. And for those, here's a commercial that I was able to watch Dr. Wilson's presentation yesterday in a wonderful panel talking really to med students around what's your role in health equity, and these kinds of issues around advocacy, intersectionality, and really authentic engagement. It was a wonderful conversation, so I want to make sure folks grab a hold of that.
I'd like to say, even when it comes to advocating, as you're bringing awareness, there's like that fine line there. Mm-hmm. As you're making folks aware, you're also advocating for them to take a stance and to begin to understand, because once people understand, then they can better advocate for themselves, which is why it's important that we focus on even, health literacy, and making sure that, when they're going to see that physician is taking the time to ensure that that patient understands. And if that patient is someone that sometimes has a limited, English proficiency, and sometimes that's not a foreign language. Sometimes that's because I got a 3rd grade education, okay? So beginning to take the time to bring awareness is an opportunity for people to learn how to advocate as well.
Thank you. We have time, I think, for one question, if anyone would like to join the conversation.
If not, then I would really wanted to add to what Floritta had actually just mentioned. Don't underestimate the power of storytelling. It's so critical to be able to identify the challenges, and people's real life, real story can actually make a huge difference. And keep in mind, those who are actually living the situation, their story itself can also be the piece that can relate or can actually be move decision makers. So in a sense, that it's not really lobbying for any particular policy per se, but a lot of times just the story can make a difference.
So I'm going to make one last plug. Peter's, I see now they're like, why'd we ask her to be on the panel? So something that came up, Vasharia mentioned voter registration. And a couple things that I would say, at least in the health center space, so a long time ago, like 2007, we launched Community Health Vote in order to get health centers more engaged in voter registration and civic engagement. What we discovered in the data was that most of the patients had never even been asked. They'd literally just never been asked. But here's the other thing. When we looked at staff in health centers, then the percentage of staff who were registered to vote was really low, like under 20%. And so whether you're in a health center, it doesn't matter the organization, I think the lessons that I would just call out, ask the question, do you want to vote? And if it's not, do you want to vote? Do you want to engage? Do you want to tell your story? Do you want to get invested? Because I think it is about empowering people. You're 100% right. But also just look right in literally at your table. Because I think sometimes we focus very much, as we should, on the community, but we're forgetting that the people right at our table sometimes are not engaged the way that we would love them to be, and giving them that opportunity too. We have an election really soon, so this is relevant right now. That's my other plug. Thanks, Peter.
So this has been amazing. I feel like I could sit here all morning, but also bring more coats before I freeze. But it's been really delightful to have this conversation. It's a spark, hopefully, for you to have conversations like this. Please talk to us afterwards as well. And I'm mindful that the way this has been designed, which I love, is what is your call to action? And we didn't have time to really talk about that as panelists, but I also want to quote something that I feel like has emerged as a theme from yesterday's sessions, and it came from Dr. Burgos, which is we have to show up and speak up, and we really need to light the way. So I invite you to think about what are your next actions. Hopefully you've been inspired or intrigued by these conversations. Hug a public health employee, hug a healthcare worker, hold hands, and let's make sure that we maintain the commitment that we've been talking about since the kickoff this morning. So thank you so much for your time. Please join me in thanking today's panelists.